Good morning, ladies and gentlemen. FOCP is pleased in collaboration with Tawam Hospital to introduce Dr. Ahmed, consultant oncologist at Tawam Hospital, to give us a health webinar about lung cancer, signs and symptoms, screenings, and prevention modalities. The slot is over to you, Dr. Diaeddin.
Hello, I am Dr. Diaeddin, consultant medical oncologist at Tawam Hospital. November is a month of lung cancer awareness, and this is why I am going to talk to you about lung cancer awareness with the subtitle of Save Your Life, Prevent It Before It Happens. It's very important before we talk about any problem to define it. And defining lung cancer, it's a cancer that starts in the lungs. When a person has lung cancer, he has abnormal cells that cluster together to form a tumor. Next is to define the magnitude of the problem. And this is data from the whole world. And if we look at the incidence, for example, we can see that lung cancer is the second most cancer in both sexes. Female breast is number 1, and lung cancer is number 2 with 11.4% of the cases, which was estimated at about 19.3 million new cases in the whole world, all cases of cancer in 2020. It is the leading cause of cancer-related death. 18% of the cancer-related death is because of lung cancer. And if we combine colorectal related cancer death and liver related cancer death, we see that lung cancer, it's almost equivalent to both of them. When we look at the lung cancer in men, we see that it is the highest incidence of cancer in men, around 14.3% of the cases out of 10 million total number of cancer cases. And it is number 1 cause of death, with about 21.5% of cancer-related deaths caused by lung cancer. In females, it is the third most common cancer, with 8.4% of the cases diagnosed as lung cancer in females. Breast remains number 1, 24.5% of the cases. However, when we look at the mortality, we see that lung cancer causes 13.7% of the total cancer-related death cases, becoming the second cancer-related death after breast cancer. If we look at the cases in the United Arab Emirates, we see that the lung cancer is the 4th most common cancer diagnosed in the country, representing about 5% of the cases. And when we look at the lung cancer stage distribution, we see that the majority of the cases present with widespread disease, meaning stage 4, about 70% of the cases. So what are the lung cancer risk factors? And here allow me to take a little bit longer time talking about smoking, because smoking is the main cause of lung cancer. It is the primary risk factor for the development of lung cancer, accounting for approximately 90% of all lung cancers. The risk of lung cancer in the long-term smokers compared with the lifetime non-smokers vary from 10 to 30 folds, and the cumulative lung cancer risk among heavy smokers may be as high as 30%. The lifetime risk of lung cancer in never smokers is 1% or less. The risk of lung cancer increases with both the number of cigarettes smoked per day as well as the lifetime duration of smoking. Other factors that may influence the likelihood of developing lung cancer in smokers is the age at onset of smoking. So the younger the higher the risk, the degree of inhalation, the tar and nicotine content of the cigarettes, and the use of unfiltered cigarettes. This is just to show some data about the risk of lung cancer and its relation to the exposure and to the number of cigarettes smoked. If we look at the left picture, we see that the current smokers have somewhere between 20 and 25 times higher risk of developing lung cancer. Former smokers, the incidence falls by almost half, and non-smokers, it is very low at about 1%. Also, if we look at the duration and intensity of smoking in men, and we see here that those who smoke more than 20 cigarettes have the highest incidence of lung cancer, which starts as early as the 30s, and it has a peak in the 40s to 50s. We have less incidence in people who smoke between 10 and 19 cigarettes, and lowest if they smoke less than 10 cigarettes. So definitely it shows us that the duration and number of cigarettes smoked per day have very high importance in the development of lung cancer with time. Secondhand smoking also is an important cause of cancer, lung cancer, occurrence and death. Non-smokers exposed to secondhand smoke have approximately a 20% increased risk of lung cancer. And there is a dose-response relationship between intensity of exposure and relative risk of lung cancer. Very important here to mention that if you work in somewhere, a place where there is a lot of smoke, the shift itself, if we're talking about 8 hours, for example, it's almost equivalent to 1 pack of cigarettes. So cigar and pipe smoking also, there is a risk of lung cancer. However, it is lower than with cigarettes. It's around 5 times more as compared to non-smokers. Heat not burn tobacco products also might be related. This is something new, and the relation is not very clear, but definitely it is there, although it is less, as I already mentioned. Just if we look at the content in these cigarettes, nicotine, for example, it's around 84%, the amount found in traditional cigarettes, whereas the volatile organic compounds or the polycyclic aromatic hydrocarbons and carbon monoxide are all there, but definitely in lower amounts. Whether this translates to lower health risks is uncertain. Water pipes also are associated with lung cancer, carbon monoxide poisoning, and other respiratory diseases. There's also the family history. Among never smokers, risk increased by 50% in association with a family history of lung cancer, and the risk increased with the number of relatives affected. Other risk factors include radiation exposure, air pollution, and occupation. Mainly when we talk about the occupational and environmental carcinogens like asbestos, radon, and hard metal dust. There are also some workers in certain occupations are at higher risk. Example, those working in aluminum production, steel founding, painting, and rubber production. So how do we diagnose lung cancer? And here the diagnostic tools include clinical, labs, and imaging. And when we talk about clinical, we are talking about the most common symptoms. People might have a cough that does not go away, or it gets worse. Some people have chronic cough. So if this cough gets worse and never improves, it's an alarming symptom for possible lung cancer. Coughing up blood or rust-colored phlegm, persistent lung infection or recurrent lung infection, again, It might occur because of the obstruction caused by the tumor in the airway passage. Wheezing, chest pain when breathing deeply, coughing or laughing, shortness of breath, or feeling tired or weak, also unexplained weight loss or loss of appetite. One more other symptoms which are not included in this picture are related to the sites of spread of cancer outside the lung. For example, if people have spread of cancer to the bones, they may have bone pain. If it's spread to the brain, they might have headache, or to the liver, they might have abdominal pain. So these are symptoms related to the site of metastasis. How frequent we see these symptoms? The most common is the cough, around 50 to 75% of the cases, hemoptysis in 25 to 50% of the cases, dyspnea or shortness of breath about 25% of the cases, and chest pain 20%. So how do we diagnose? We already mentioned the clinical aspect. Here we talk about the approach related to the imaging, chest X-ray, CT scan of the chest, PET CT scan, bronchoscopy, and most important is tissue biopsy. We have to confirm the presence of the lung cancer through the biopsy. How do we do the tissue biopsy? Through bronchoscopy and endobronchial biopsy, or under CT scan guidance from a lung mass or from a site of disease spread. How do we define the extent of the disease? This is something, again, very important when it comes to the way we manage such patients. This is just to show you the different stages of lung cancer. We talk about 4 stages: stage 1, stage 2, and stage 3. These are stages where the cancer is still localized in the lungs, whereas stage 4, we can see that the cancer has spread outside the lungs. It can go anywhere in the body. It can go to the liver, it can go to the other side of the other lung, it can go to the brain, it can go to the bones. So it can go anywhere in the body. And defining the extent of disease is very important. It simply tells us what is the future of the patient. People who have, for example, stage 1 disease, they have a chance of living for 5 years about 92%. Whereas people who have stage 4 disease or cancer, their chance of living 5 years is 0. Of course, this is not for all cases, and we'll come to some of these later on in the presentation. The treatment of lung cancer includes surgery, radiotherapy, chemotherapy, targeted therapy, or immune therapy, any one of these as single modality or in combination. This is how the lung cancer treatment evolved over the years. We started initially talking about lung cancer as one cancer. And with time, we realized that, in fact, we are talking about 2 different cancers, the small cell lung cancer and the non-small cell lung cancer. And later also, we started talking about the non-small cell lung cancer, not as one entity, but as more than one entity, like squamous cell carcinoma, non-squamous cell carcinoma, which includes the large cell and adenocarcinoma. And in the recent years, we started talking about subtypes of lung cancer. And this is just, if you look at this pie, you see these small fractions. These are all representing different subtypes of lung cancer, which are treated differently. And most recently, we started talking about also the immune therapy and the role of some of the markers we use to guide us in the way we treat such patients, whether we go for immune therapy as single agent or for immune therapy in combination with chemotherapy. And this is just to show how different is the treatment of lung cancer And these are some of the markers we look at what we call PD-L1 expression. And this is given a score, more than 50% or less than 50%. And according to this, patients are treated. And just to complicate the picture as well, because we have so many subtypes of lung cancer nowadays, and each one of them has different treatment. For example, EGFR mutation, ALK positive, ROS1 positive, BRAF positive, NTRK positive, RET positive, METX14 positive. So every one of these has a treatment which is different from the other. And this has improved, really improved the prognosis. It improved the outcome of treating patients with lung cancer, where some patients are living for years and years. I can tell you, we are seeing patients who are surviving more than 5 and 6 years as well. And maybe we hope here for cure, hopefully in the near future. So this is, again, to show having a closer look for the subtypes. And simply you can see, for example, look at the SPY, and you can start counting, for example, 1, 2, 3, 4, 5, 6, 7, 8. So we are talking about several subtypes of lung cancer, and each one of them has different treatment. Each one of them has different response to treatment, and some patients, as I already mentioned, are living for years and years, where we can start hoping for cure for such patients. And this is again related to the approach and the PD-L1 status. Most important is to prevent the cancer. We don't want people to have lung cancer. We want them to prevent the lung cancer. And how we prevent it? By stopping smoking. If you continue smoking, look at the graph, how it goes sharp up. If you stop smoking at 60 or at 50 or at 40 and at 30, or you are non-smoker, look at this graph, how nicely it will go down. So it's very important, do not smoke. Smoking cessation decreases the risk of lung cancer. The reduction in risk becomes evident within 5 years, with a progressive decline associated with an increasing duration of abstinence. Former smokers abstinent for more than 15 years have 80 to 90% reduction in risk of lung cancer compared with current smokers. The risk remains higher than in the never smoker, even after prolonged periods of complete abstinence, but definitely it's 80 to 90% reduced. And the risk continues to rise with age, even after smoking cessation, but it rises at much lower rate than it would have had smoking continued. Smoking reduction, and this is for people who are unable to quit, also is very important. Encourages them to decrease smoking may result in harm reduction. Just to give an example, an observational study that included almost 20,000 people, it found that smokers who used to smoke more than 15 cigarettes or an equivalent amount of tobacco in another form per day, and who continued to smoke but cut back by at least 50%, reduced their risk of lung cancer by 27% after a mean follow-up of 18 years. Early detection decreases mortality. And here we talk about lung cancer screening. It saves lives. So people who are at high risk should have lung screening. People between 55 and 77 years, currently smokers, or quit in the last 15 years, and they have smoked at least 30 packs a year. So meaning either 2 packs per day for 15 years or 1 pack per day for 30 years. And how do we do it? Simply with a CT scan, low dose CT scan. This is the old These are the current guidelines. Even the age is increased rather than 77, it is up to 80 years, and the rest is almost the same. And these are from 2 different organizations. Back to the overall survival by stage. Why to do screening? Simply to detect cancer in early stage, so people have better chance for cure. Again, look at this table at 60 months. So 60 months survival is highest at stage 1, 92%, and it is lowest when it comes to stage 4, A and B, where it is somewhere between 0 and 10%, 5 years survival. Already, I mentioned that the low-dose CT scan reduces mortality by about 20%. So screening is very important. People who are at high risk should go for lung cancer screening with annual low-dose CT scan. But again, I say and I insist, prevention is the way to go. At the end, let me finish here saying your good health is in your hands. You take care of it, you save it, you ignore it, you lose both your health and your life. To decrease risk of lung cancer, quit smoking, encourage others to quit as well. Quit smoking, encourage others to quit as well. And with this, I would like to thank everybody. Thank you for listening, and I hope I was of some help for all of you. I hope all smokers quit smoking after this presentation. Thank you.
Thank you so much, Dr. Diya, for such an informative and useful session. I would like to, at the end of the day, I would like to request our audience to subscribe our YouTube channel for the similar awareness sessions and updates. Thank you so much.